So by way of introduction, the idea for all of us and our goal for every patient with diabetes is to fast safely. And to fast safely means that there should be no hypoglycemia, no hyperglycemia, no hyperglycemic emergencies such as a diabetic ketoacidosis or hyperosmolar state, and hopefully no deterioration in their glycemic control over the month of Ramadan. Self-monitoring of blood glucose, or SMBG, is an essential component of diabetes care, and patients should be, and all individuals with diabetes, as well as their families, should be provided with the tools and the knowledge to carry out self-monitoring of their blood glucose. This is essential so that they may be able to self-manage their disease during the month of Ramadan without constant contact points with their healthcare practitioners, which are often not possible. And furthermore, to prevent as well as to identify hypo and hypoglycemic problems during the month of Ramadan. Now, the frequency of self-monitoring of blood glucose depends on many different factors, including the type of diabetes, as well as the current medication. But it should be emphasized that it should be carried out regularly by all patients. So for those individuals who are assessed as being at moderate to low risk of having adverse events, they may test their glucose levels once or twice a day. So these are patients who have a very low hypoglycemic risk. They have had no hypoglycemic emergencies, and ideally should not be on insulin or sulfonylurea therapies. So ideally, these are patients who are on metformin, DPP-4 inhibitor, SGLT2 inhibitors, and often have no complications of their disease. Those at very high risk should obviously be counseled about the possible risk of fasting. But for those patients who are adamant that they want to fast, as well as those patients who do not fast but may modify their lifestyle significantly during the month of Ramadan, so as not to appear out of sync with their family members, they are at risk of increased risk of adverse events. So for these patients, especially those using more complex regimens, so multiple daily doses of insulin, or those who have a higher risk of hyper and hypoglycemia, such as unawareness or frequent excursions of hyper and hypoglycemia, these patients should be advised and educated that they need to test their glucose levels much more frequently. Patients should also be educated that in addition to testing their glucose levels at set times where we anticipate problems or we are using those readings to titrate doses, they should also be educated that if they experience any symptoms of hyper or hypoglycemia, they feel unwell, or they are unsure, they should immediately test their glucose. And if that's not possible, they should consider terminating their fast. Just in terms of practical considerations, there's still a misconception amongst many patients that by testing their glucose, they may invalidate the fast. And we must educate them and re-emphasize at the pre-Ramadan visit that testing, no matter how many times they test, will not invalidate their fast. The recommended times for fasting, as I said earlier, depend on the intensity of therapy as well as the patient's risk profile. But I thought briefly to go through some of the times that are advocated. So we often suggest that they should test at the pre-dawn meal, and that gives them an idea of, especially those patients on insulin, as to what their glucose levels are at prior to the fast. If that patient's readings are running a little low, perhaps that patient should consider decreasing their dose of insulin, as the risk of hypoglycemia would be increased during the course of the day. The second point would be in the mid-morning. And the main purpose of that for the average patient is if that patient is actually on insulin therapy, then it allows them to assess whether the morning dose was adequate. Once we get later in the day, the risk of hypoglycemia increases. And as we've seen earlier, the highest risk of hypoglycemia is in the late afternoon as we approach the iftar period. So that is, if a patient is only going to test once or twice a day, that should be the one time that has to be emphasized. The fasting that we usually do in the non-prandial state, which is in the morning, now should be done just prior to iftar as the patient is about to terminate their fast. The 2-hour test post-iftar, although ideal, especially for those patients who are taking insulin at the time of the fast, termination of the fast, allows them to evaluate whether the prandial dose of insulin is actually sufficient and whether they need to modify their diet in the subsequent days. The challenge with this is often these patients are then at the evening or Taraweeh prayers and often is not done. The patients, once again, should be reminded that at any time, if they have symptoms of hypoglycemia, they should test their fast. So this is the ideal, and this is what we should be educating our patients at the pre-Ramadan visit. I'm now going to take you some new data, which we've derived from the Diabetes and Ramadan survey. And we're first going to look at the type 1 cohort. There were 2,108 patients. And if you look at it, the majority of patients, at 62%, tested at the same frequency as they did before Ramadan. Now, we do know that Ramadan is a setting in which these patients are at a higher risk of developing both hyper and hypoglycemic complications. And you would have expected that a higher proportion than 23% would have actually increased the amount of SMBG. However, what is for me very concerning is that about 15% of patients test even less frequently than they do out of Ramadan, with 8% testing less frequently and just under 7% not testing at all. And these, just as a reminder, these are patients with type 1 diabetes who are usually on more complex insulin regimens. If we then look at, for those patients who did perform SMBG, how frequently did they actually test their glucose during the month of Ramadan? And once again, we've got about just over half of these patients testing 3 to 4 times a day. We've got about 20% who then tested twice a day, and perhaps these were a small subset of patients who want twice daily premix insulin. I'm not sure, because that we don't have that data as yet. But what is of greater concern is when we look at those who said they did SMBG, just about 25% are actually testing suboptimally. We have under 4% testing less than once a week, another 3% testing once a week. And cumulatively, these patients are probably going days where they're not actually monitoring their glucose levels. And this exposes them to both hyper and hypoglycemic risk. Going on to the type 2 cohort, where we had about 11,500 patients, the same question was posed, whether they did SMBG during Ramadan. About just under half of them said that they continued monitoring their glucose levels at the same frequency as they did before Ramadan. And only 13% actually increased the amount of monitoring. Well, for me, what I thought was of great concern, was that a quarter of these patients were not testing at all. Now, it may be that within this overall cohort, there were patients who are on DPP-4 or SGLT2 monotherapy and were at very low risk of hypoglycemia. And perhaps they felt they were fine if they were relatively well controlled. But as we see later, even in the insulin controlled population, there's still a problem. Right? So just under 40% of patients are actually not testing optimally. When we look at those who did test, they were then asked, how many times per day did you monitor during the month of Ramadan? And we see that a very small proportion, under 10%, actually tested 3 to 4 times daily. And although this is a type 2 cohort, I'm sure that there are more than 10% of this population that were on more complex insulin regimens and probably would have required multiple daily testing. What's also of concern is that when we look at those who are testing once weekly or less than once weekly, we once again getting to around 40% where these patients are actually testing suboptimally. And when we look at this, in addition to that 25% who are actually not testing at all, I think there's a great need to improve education amongst patients with type 2 diabetes and monitoring during the month of Ramadan. Looking at the insulin-only cohort, those who are using insulin, they were divided into 4 groups. In the blue were those who are using basal insulin with sulfonylureas. The next group in the orange color were those who were using other combinations of insulin with sulfonylureas. We then had in green those who are using basal insulin on their own without a sulfonylurea, and then those who are using multiple or other combinations of insulin in addition to basal insulin without a sulfonylurea. And what's concerning to me is that in this insulin-using cohort, including those who are on more complex regimens, you still had between 20 and 30% who are not testing at all, suggesting that these patients are probably at a much higher risk of adverse events. In terms of those who are actually testing more frequently, it's a relatively small percentage. And again, it's around 20%, and those were just on basal insulin with sulfonylurea. So at least 80% of our patients are probably not doing what they should be doing. When we then look at the different insulins and we look at the frequency of insulin, we'll see that the ideal, which is 3 to 4 times daily for those patients who are on other combinations of insulin is below 15% throughout. And if you average it out, it's probably around 12%. There are those who are testing once and twice daily, which make up about a third of patients. But we then once again see many patients, despite being on complex regimen, so those who are taking combinations of insulin in addition to sulfonylurea, who are probably on one of the highest risks of hypoglycemia, only 23% of them, actually 23% of them are actually testing less than once a week, which is obviously of great concern. So I think our take-home points is that SMBG is an essential component of safe fasting and is an integral part of the pre-Ramadan education. Of concern is that a quarter of patients with type 1 diabetes are performing SMBG with suboptimal frequency. Another quarter are actually increasing the frequency of SMBG during Ramadan, and that at least is reassuring that there are some patients who are now adapting to the month. When we go to the type 2 cohort, a quarter of the patients do not perform SMBG during Ramadan at all. 36% of patients perform one or few times one or fewer than one times per week during the month of Ramadan. And despite being on insulin, a quarter of the patients do not perform SMBG. So we seem to have this trend of a quarter of patients and monitoring, and a half of that are only actually doing what they really should be doing and treating and monitoring as per the DAR guidelines. What is required is further analysis and research to assess whether the impact of SMBG frequency on outcomes, and as well as the poor reasons for alignment between what patients are doing and what the guidelines are advocating. I would thank you for your attention, and would like to acknowledge Professor Mohamed, who's been a good friend, mentor, and colleague for many years, as well as the contributors to the chapter on monitoring in the DAR guidelines. Thank you.